Hi, I'm Paul Epstein, and I'm just going to talk to you a little bit about the pharmacotherapy of anxiety. So, some of the objectives to come away with today would be to learn the pharmacology of anxiolytic and sedative hypnotic drugs. I include them both here because many of these agents are used both for as anxiolytics as well as sedative hypnotics, though I won't talk very much about the sedative hypnotics here. Uh, so you want to know what receptor systems the benzodiazepines and the earlier drugs that were used before them, like barbiturates, interact with, what effects are produced by the interaction, how the effects are brought about. You should be able to highlight some of the very main differences between benzodiazepines and barbiturates. And in case of the benzodiazepines, you should know something about how their structure influences their pharmacokinetics, because they mainly differ in their pharmacokinetic properties. And on your own, you could maybe learn a little, or you could see them in some of the slides that I won't necessarily show in this video, about how some of the newer sedative hypnotics differ from the benzodiazepines and barbiturates that we used earlier. Okay, so what's used now to treat anxiety? Uh, Basically, the barbiturates were dominated from about 1900 to 1960, and then the benzodiazepines first became available in 1960. The first one was chlorodiazepine epoxide, or Librium, in 1960, and that was followed by diazepam or Valium in 1962. And those were the main drugs used for treating anxiety for at least 40 years until about 2000. They're still in use today, but they've largely been superseded for long-term treatment of anxiety by the serotonergic antidepressants, particularly the SSRIs, um, which were found to be safer and actually in some ways better for long-term treatment of anxiety. There's also one agent, an azapirone, called buspirone, trade name Buspar, which is totally different from any of these others. But it's only useful for treating one form of anxiety, which we call GAD, or generalized anxiety disorder. You'll see on the next slide there are a variety of types of anxiety that we can define. Uh, that's seen here, and a pretty common one is generalized anxiety disorder, which is defined by consistent worrying and over and above what a normal amount for a period of 6 months or longer. There's also, of course, social anxiety disorder, which is kind of, as the name suggests, it's kind of a fear of social interaction and talking to people and getting out into the public. There's obsessive compulsive disorders. There's panic disorders, which is characterized by these not infrequent panic attacks that come suddenly and can last, up to maybe 30 minutes or so, and can disorient somebody. There's post-traumatic stress disorder, which arises from having been a victim or a witness of trauma. And then there are simple phobias of different things, like fear of flying, for example. Now, all of these types of anxiety are characterized by increased sympathetic tone. So, if we look at anxiety circuitry, what we find is that what do we see? We see things like increased heart rate, increased blood pressure, dilated pupils, dilated bronchioles, reduced bowel tone, closure of urinary and anal sphincters, increased sweating, and activation of erector pili muscles, which are the muscles that make your hair stand up, like in a cat. If you've seen a cat, that happens to be afraid. So one way you might think to possibly address a case of overactive amygdala that's causing this increased sympathetic tone would be to come up with ways to reduce the release of norepinephrine, for example. There, there are there are ways. There are some drugs available that work in different parts of the nerve terminal that can do that in some ways. But with the ones I have diagrammed here, none of these are really very effective at all in terms of anxiolytics. They're used for other things. There's clonidine, which is an agonist of the alpha 2 presynaptic autoinhibitory receptor, which can inhibit the release of norepinephrine, but it's a very weak if anxiolytic. It's primarily used as an antihypertensive agent. There's something called beryllium that can also inhibit the vesicular release of the norepinephrine. It's not in use any longer. It used to be used as an anti-arrhythmic agent. I do recall when I was watching Steven Spielberg's movie E.T. back in, I guess it came out in 1984. E.T., or the extraterrestrial, was dying of ventricular tachycardia, and they used beryllium to keep him alive. But in any event, it's not in use. Propranolol, you should be familiar with, is a non-selective beta-adrenergic antagonist, and that can work by inhibiting postsynaptic beta-adrenergic receptors, and it is used to some extent as a to combat performance anxiety, because it seems to take care of some of the symptomatic manifestations of the anxiety, but the somatic manifestations, but it doesn't really treat the anxiety per se. So there's another way that we have to dampen the excitatory neurotransmitter like norepinephrine, and I show that on the next slide. And that is where you could have an inhibitory neuron, like a GABA neuron, as diagrammed here in the upper right, impinging on this nerve terminal that would normally release norepinephrine. And GABA, gamma aminobutyric acid, as you know, is the very most abundant inhibitory neurotransmitter in the brain. I think it's believed as many as 50% of all the neurotransmitters in the brain utilize GABA. And if you can activate the release of GABA, it would provide a global dampening of all the excitatory neuroeffector junctions or neurotransmitters, nerve terminals throughout the brain. So you can calm somebody down certainly that way. So how does GABA do that? Well, there are two receptors that GABA can interact with. We call them a GABA A and a GABA B receptor. I'm just going to concentrate here on the GABA A receptor because all of the agents we're talking about only work through that one. They're very different. The GABA A receptor is far more abundant than GABA B, and it's an ionotropic receptor. The GABA B is a metabolotropic receptor that's coupled to G proteins. And the GABA A receptor passes it, so it's a channel as well as a receptor, and it can pass chlorine. So what happens is when GABA binds to a GABA A receptor, here as indicated here, it would open a chloride conductance. And what happens, show you on the next slide. So what happens is where you see E, that's an excitatory neurotransmitter. Normally that would increase the membrane potential till it gets to a threshold, and then you get an action potential where the nerve fires, and you get an effect. If you have something like GABA come along the eye here, and it opens a chloride conductance, it's going to hyperpolarize that membrane and cause what's called an IPSP, or inhibitory postsynaptic potential. And if chlorine, in the case of chlorine, the concentration of chlorine inside the nerve terminal is about 4 millimolar. Outside, it's about 120 millimolar. And from the Nernst equation, you would come up with an equilibrium potential of minus 87 millivolts. So when you open a chloride conductance, the potential of the membrane will go towards equilibrium, or minus 87 millivolts, and that's your IPSP. So then when you come along with an excitatory neurotransmitter, it will again increase the membrane voltage, but not enough to reach threshold, so you don't fire the action potential. So that nerve terminal is shut off. Okay, so again, this just repeats that the GABA A is more abundant than the GABA B. It has a pentameric structure that forms a chloride channel, and it provides for the very rapid inhibition by enhancing the chloride conductance. And when you look at the molecular biology of these GABA A receptors, there are about 19 different subunits that it can be formed from. So these GABA A receptors are highly heterogeneous. You can do a permutation of that. You'd get about 150,000 possible combinations. But so far, we've only identified about 500 that exist. But the other very important thing about the GABA A receptors is that they are the target for many extremely important drugs that are in use widely for many things. And I'll show you that on the next slide. And this is just an idea of all the various kind of drugs that act through an action by binding to a GABA A receptor, this ionotropic chloride conducting channel receptor. The anticonvulsants work that way, sedative hypnotics, anxiolytics, which we're mainly talking about here, muscle relaxants, antispasmodic drugs, inhalational anesthetics are now believed to work through GABA A receptors. There are neurosteroids that act through there, and alcohol. That's one of the targets of alcohol. So looking at the structure of this, the structure, looking at the structure of this, the GABA A receptor is made of 5 subunits, pentameric. Each subunit spans the membrane 4 times. Between the third and fourth intramembrane spanning area, there's a large loop, and that can be a target for modulation by cyclic AMP-dependent protein kinase, indicated with the P. It can phosphorylate there. But the structure of it is they all contain 2 alpha subunits, 2 beta subunits, and a 5th subunit, which could be gamma or a gamma-like subunit. Now, all the different drugs that interact with it are shown on this next slide. Here, these represent, these things I drew here represent alpha subunits. And there are distinct sites on these alpha subunits for all these different types of drugs. So GABA binds in one region, and we know they're distinct because there's distinct pharmacology for them. So the GABA site, the GABA site, there's an agonist called muscimol and an antagonist called bicuculin. You don't need to know that or remember that. But there's a separate benzodiazepine site, and we have various agonists for that, which are all in clinical use now, like diazepam is a prototypical agonist for the benzodiazepine site. We only have one antagonist, and that's flumazenil, that can antagonize the binding of benzodiazepines and reverse their effects. There's also barbiturates and anesthetic sites, which are believed to be much closer to the channel itself, to where the chloride comes through. And also the neurosteroid sites are believed to be somewhere near there as well. So all these different things, including ethanol and inhalational anesthetics, interact with this receptor system. Okay, the next slide again shows the molecular biology of the GABA A receptor. I mentioned there are 19 subunits cloned. There are 6 alpha, 3 beta, 3 gamma, and then these others like delta, rho, etc. are gamma-like, but specific for different tissues. The thing to remember here is a couple of things to remember. One is that although the benzodiazepines bind, if you do direct binding studies, you can show that they bind to the alpha subunits, but it's not as simple as that, because all the benzodiazepines also require gamma 2 for their effect. So likely they're binding at the interface between an alpha and gamma subunit. The other thing to remember is, of the 6 alpha subunits, the alpha 4 and alpha 6 subunits don't support benzodiazepine sensitivity. They act clearly as chloride channels and respond to GABA, but the benzodiazepines have no effect on if the GABA A receptor contains only alpha 4 or alpha 6. Benzodiazepines won't bind to it. You can see on this slide just what I just said. And the reason is that there's a conserved histidine group in the N-terminal tail required for the binding of the benzodiazepine. And in the alpha 4 and alpha 6 subunits, that histidine is substituted by an arginine. So the benzodiazepines don't bind and they don't respond to benzodiazepines. So what happens when you add GABA or a benzodiazepine to a neuron? You can put a neuron in culture and measure chloride conductance, and you can see. And what happens is this downward drawing that I put here, when you add GABA to the neuron, is showing a chloride conductance. And what happens is diazepam potentiates that chloride conductance, specifically by increasing the frequency of opening of the channel. So if you add diazepam like the benzodiazepine by itself, what's going to happen? The answer is nothing. The only thing the benzodiazepines can do is potentiate the actions of GABA by increasing the affinity of GABA for binding and increasing the frequency of opening of the channel. But if you just add diazepam by itself, it won't do anything. This is where it's distinctly different from the earlier barbiturates. I mentioned the barbiturates seem to have the binding site right in the chloride channel where it's passing through. So there is a difference. Okay, as you see on this slide, the binding site is distinct, and variations in the subunit composition don't affect the barbiturate sensitivity. Barbiturates will interact with all forms of GABA receptors, and most notably, at higher concentrations, the barbiturates become GABA mimetic. What that means is they can open the channels by themselves. So unlike the benzodiazepines that don't do anything by themselves, barbiturates will open a chloride channel, and consequently there's a very big difference in the safety of these two agents. You can see on this slide, as you go up in benzodiazepine concentration, you go from sedation to hypnosis to anesthesia, and it plateaus there. So you don't go into a coma, and typically you wouldn't die from a benzodiazepine overdose if you take a benzodiazepine by itself. All bets are off if you're taking it in conjunction, say, with alcohol, which can potentiate its actions, and so that's different. But barbiturates by themselves are lethal. As you go up, you go beyond anesthesia into coma and death. So that's why the barbiturates, although they're used for other things, still very much for some forms of epilepsy, they really have been replaced almost virtually entirely. as anxiolytics and even as sedative hypnotics. So you don't need to consider them as far as treating anxiety. I don't think they're in very much use at all. Okay, so now I want to talk about differences in the pharmacokinetics because there are quite a lot of benzodiazepines, at least a dozen, I would say, that have been synthesized and are in clinical use. And again, they're in terms of efficacy, they're similar, but they can differ widely in the pharmacokinetics in terms of two things. One, in terms of rapidity of action, and two is length of action. So, in terms of rapidity of action, I think you probably know that the ones that are more hydrophobic or less charged or lipophilic, let's say, would get in the brain faster and then would have a much faster mechanism of action. So the next slide shows a comparison of two benzodiazepines. Diazepam, which is Valium, which is a sort of prototypical agent, happens to be very lipophilic. It perhaps is the fastest acting of any of them in terms of getting into the brain and producing an anxiolytic effect. The benzodiazepines work immediately. There's almost right away. Now, the difference in structure between these two, if you look at them, there's two differences. Okay, the structure of benzodiazepines, typically they have two benzene rings fused with a third ring that's a seven-membered ring. In that seven-membered ring, the diazepam has a methyl group, which is missing from oxazepam, and you note that there's a 3' hydroxyl group on the oxazepam, which is not on the diazepam. So you may be able to tell right away, I don't know to what extent this was covered in core, but which one would be shorter acting. Okay, if we go to the next slide, you can see the oxazepam having that free hydroxyl group would be able to get conjugated with glucuronic acid and excreted directly without having to be metabolized by the mixed function oxidases or cytochrome P450 enzymes in the liver. So that would be much shorter acting than diazepam. Typically, diazepam gets N-demethylated, then it gets hydroxylated at the 3' carbon of that seven-member ring to form oxazepam, and then it can be conjugated and excreted. Now, there are two benzodiazepines that are different in structure from all the others, and we call them triazolo benzodiazepines. The next slide shows those. The two are triazolam and alprazolam, and what they have is the same structure of those three rings, but to the seven-membered ring is fused an imidazole ring as well. So these two agents have kind of a wider, they seem to have a wider action than the other pure benzodiazepines. So they have some side effects that you don't see with the others. The trade names of these, triazolam, the trade name is Halcyon, and for alprazolam it's Xanax. And for a very long time, Halcyon was one of the main sedative hypnotics used to treat insomnia. Not so much anymore. It has extremely short half-life, about 2 hours. It would cause some rebound insomnia, and also after being marketed for a while, it was realized that some people would develop things like hostility, and they'd play out in physical ways, and it wasn't even considered that safe. So it was almost withdrawn from the market, but the FDA just cut the dose, the maximum dose in half. So it's still available. And the alprazolam seems to have a greater propensity for developing dependency than the other benzodiazepines. Although all the benzodiazepines, when taken for a fairly long time, cause a physical dependency, and it's very, very difficult to get off these. Now, these two agents, they're metabolized differently. They're metabolized to something called alpha hydroxy metabolites and then rapidly excreted. So they happen to be short acting as well, similar to the other benzodiazepines in a way that had that free 3' hydroxyl group. Okay, so here you can see the metabolism of these. What happens is many of these benzodiazepines are all metabolized to a common intermediate called desmethyldiazepam, which is just diazepam with that methyl group removed. And that's important to know because desmethyldiazepam is an active, very long-acting metabolite, has about a 100-hour half-life. So, and sedation is a common side effect of all benzodiazepines. So, for those that produce this desmethyldiazepam intermediate, it's probably not a good idea to be treating somebody chronically with these because they'll tend to have a lot of daytime sedation. So instead, you could use a shorter acting one, particularly the one on the right here, lorazepam, which would also like oxazepam has a free 3' hydroxyl group. The trade name of lorazepam is Ativan. It's shorter acting, doesn't require metabolism by the mixed function oxidases. It can be directly conjugated with glucuronic acid and excreted. So you don't have as much daytime sedation with that one, for example. Okay, so there are a couple of other compounds that I wanted to just mention a little bit about, which we already brought up briefly. One is this flumazenol, which I've said is the only benzodiazepine antagonist that we have. And it's used to reverse either benzodiazepine overdoses, or it's also kept available in cases where benzodiazepines are sometimes used for outpatient anesthetics for outpatient surgeries like colonoscopies. Used to be used. There was midazolam or Versad, which is a very rapid, very short-acting benzodiazepine, was used for those procedures. It's been largely, I think, replaced by propofol now. But whenever you would use that, you'd have to have flumazenol available in case you need to wake the patient up. The thing about the flumazenol is that it has to be given IV because of extensive first-pass metabolism, and also it has a short half-life, so you have to give repeated doses. Okay. Now, this is the other compound, again, you should know something about, because it's structurally completely different from the benzodiazepines and works entirely differently. So it's an azapirin. It's the only one we have clinically approved. It's been around since the 1980s. A couple of things about it are, though, is first of all, it's only effective as an anxiolytic for generalized anxiety disorder, but not for any of those other types of anxiety that we had listed, only for GAD. And unlike the benzodiazepines that work immediately, this compound, buspirone, or Buspar is the trade name, can take several weeks to work. So it's not as popular amongst patients, obviously, and not as much in use as the benzodiazepines, which can work immediately. The reason for why it takes so long partly has to do with its pharmacokinetics. It has extensive first-pass metabolism, so only a few percent of it gets in, and it takes weeks to build up to the therapeutic level. But it also may be because its mechanism of action is that it's an agonist of the 5-HT1A inhibitory presynaptic autoreceptor. So if it's working on a receptor, its action may involve a downregulation of that receptor, for example, which can take several weeks to take place. Okay, so the benzodiazepines can do a lot of different things. You can see here We mentioned that it has these various clinical uses as anxiolytics, hypnotics, anticonvulsants, myorelaxants. It's also used for treatment of alcohol withdrawal because they show cross tolerance. But it also has a variety of unwanted side effects, particularly sedation is universal amongst all the benzodiazepines. They're all extremely sedative. They also all cause interrogating amnesia, impairment of motor coordination, which makes it difficult to drive if you're on them. And what was discovered is, since they've been around since the 1960s, there are people that have been on them for decades. And then it was noted that apparently they seem to cause cognitive impairment after very long-term use, which is obviously not a good thing. And that's why basically by about 2000, the use of SSRIs has supplanted the use of benzodiazepines for long-term maintenance therapy of anxiety. And they can also potentiate the effects of ethanol, which is unwanted. So the one thing you could ask would be which subunits, which alpha subunits of the benzodiazepines are responsible for which of those effects of the benzodiazepines. So it was thought initially maybe you could tell this by doing knockouts and seeing what do in animals of a particular type of alpha receptor and see what type of effect was lost. But all the knockouts turned out to be embryonically lethal, so we couldn't really do that. But a fellow named Uwe Rudolph at the University of Zurich did a series of very elegant experiments almost 20 years ago now, where he took advantage of knowing that histidine group, marked in orange here at the top, that's required for the binding of benzodiazepines, the fact that we knew that in alpha 4 and alpha 6 that's changed to an arginine and they don't bind benzodiazepines. So what he did is he modified like the other ones, like in alpha 1, he put an arginine in place of the histidine and then inserted this gene in the embryonic embryos of the mice so that they grew up with this modified alpha 1 or alpha 2 or 3 or 5. And then he did a series of animal experiments, behavioral experiments, to look at the various consequences behaviorally of what happened if you knock in, so to speak, an altered alpha 1 receptor or altered alpha 2, etc. And the sum of what he found is shown here on the next slide. And what he was able to show is that, so looking at it just as to what was around in the chronology of agents for treating anxiety and sedative hypnosis, back in the late 1800s, one used bromides. Also, around 1900, chloral hydrate was used. It's still in use. It's a prodrug. It has to be converted to an active agent, I think, by to triethylamine or something like that. And the barbiturates came around in 1900. You saw that they were not that safe. Meprobinate was big in the 1950s. It was called Milltown. It was structurally different from the barbiturates, but it turned out they thought it would not be addictive like barbiturates, but it turns out it works directly on the same site. So it's no different from barbiturates, really. The benzodiazepines I mentioned came out in 1960. They were in heavy use for 40 years. And then we now have these three alpha-1 selective ligands, zolpidem, zaleplon, and S-zolpiclone. The trade names of those are Ambion, Sonata, and Lunesta. And those are the main agents used for insomnia as sedative hypnotics today. Particularly Ambien is probably the most used. But subsequently, more recently, there have been a couple of other things that have come out. There's an agonist of melatonin receptors called Ramelteon, and only within the last few years there's an antagonist of the orexin receptors. The orexin system is your wakefulness system. So this agent, suvorexant, instead of trying to cause sedation like all these other agents do, what it does is it blocks your wakefulness system. And it seems to be much safer in that regard and devoid of a lot of problems. So I suspect, as far as insomnia goes, this agent may supersede Ambien in due course. Okay, so finally, um, so what we have is benzodiazepine anxiolytics that are fairly safe and effective for acute short-term treatment of anxiety, very effective. But we use antidepressants, particularly the SSRIs, for maintenance of long-term therapy of anxiety. And as we said, the newer alpha-1 GABA A receptor subunit selective agonists are the current agents primarily used for insomnia. But this new orexin antagonist, I think, shows great promise. Okay, that's it for now. Thank you.